Hey, welcome. Uh, my name is Joseph Miller. I'm an emergency physician with Henry Ford Health and joined by Dominic Borgiali, who is also an emergency physician. Dominic, do you want to say a quick word about yourself?
Yeah, I'm emergency physician at Hurley Medical Center. I work for the University of Michigan, and I also am board certified addiction medicine.
Excellent. And both of us have been working with uh, MDHHS as clinical consultants over the last few years to help with medications for opiate use disorder throughout the state in terms of consulting with other departments, particularly in emergency medicine. And today we're going to talk about stigma and opioid use disorder. Again, our disclosure is that we do provide services for Community Foundation in Southeast Michigan, but don't receive other financial benefits from the prescription of medications for the treatment of opiate use disorder. And this map shows a lot of the different emergency departments around the state that we and others have worked with to try to implement medication for opioid use disorder pathways in different emergency departments and reach a lot more patients that need this kind of care. So a few objectives that we're hoping to cover today is both identifying origins of clinician-related stigma, identify stigma among patients related to medications for opiate use disorder, discuss and employ destigmatizing language and behaviors, and recognize and effectively address stigmatized behaviors among colleagues. And so maybe, Dominic, do you want to talk a little bit about just the opiate epidemic in general and where we are?
Yeah, definitely. So definitely we've seen an increase in the amount of deaths related to opiate overdose. Um, that is mainly attributed to fentanyl. Fentanyl is much higher potency medication, as we know. And there's many reasons why this happens. Um, we're trying to combat that with harm reduction, getting Narcan out in the community. But I think even up to last year, there was over 110,000 deaths in the United States from opiate use or from overdose.
Yeah. So a little bit about what stigma is. One definition from Loma et al. Is that it's the dehumanization of an individual based on the social identity or participation in a negative or undesirable social category. And I think most of us in healthcare experience this in different ways, may have experienced it ourselves. And we can think about kind of two categories of stigma, one being external or public stigma, which is attitudes and reactions towards socially excluded groups. And patients that have opiate use disorder all have, often fallen into a socially excluded group. And external stigma could come from healthcare providers, it could come from law enforcement, it could come from families, communities, all kinds of different social structures within the communities we live and work in. And there can be laws and regulations and cultural contexts that represent structural stigma. So in many ways, stigma can be, embedded in the structure of the social fabric that we live and work in. Then we often differentiate these external or public stigmas from internal or the felt self stigma that our patients or that we might experience at times. And so that experience of internalizing stigma can result in devaluation, feelings of shame, and then avoidance of situations where the shame and the stigma may arise, and so a fear of engaging in those kind of um, interactions, including interactions with healthcare providers. And then that feelings of rejection can further increase marginalization and distance um, patients or others from potentially seeking help where they may most be able to find that. And we're all aware that, the stigma around drugs and opiate has been around for a long time, probably before, but certainly heightened from the start of the war on drugs by Nixon and others over the many, many years. So, where do we see stigma? Dominic, do you want to comment a little bit about where you see stigma in
But
your practice?
definitely, yeah, yeah. So we're going to talk about kind of like the internal stigma within our patients, but then also external stigma, again, with providers and society in general, I guess you would say. Since Joe and I both work in emergency departments, we, I know we both see stigma still. We see doctors and nurses and other providers not wanting to quote deal with those patients. Um, the stigma of opiate use disorder or substance use disorder um, is pretty prominent in the emergency department. In general, in healthcare, it's there as well. Um, I think you have some slides about specifics there, but definitely we still see it abundantly pretty much every day. People come into the emergency department, they've hit rock bottom in a lot of situations, and
Mhm.
um, people have fatigue. Healthcare providers have fatigue in taking care of patients that have um, mental health issues or substance issues. So I think that's a lot of where we see it every day.
Yeah, and right, it's definitely present commonly both, not just our nurses and physicians, but it can be our um, everyone from our environmental services employees to our police, kind of internal police group that helps protect the emergency department. I remember doing some calls with different physician groups in some of the smaller communities of Michigan, and their medical directors describing resistance in prescribing, or in implementing protocols around medications for opioid use disorder because of perceptions among a lot of their older staff that that you know it was the patients were it's their fault that having these that they're having problems with addiction, and a resistance to trying to work hard to help them in seeking long-term care.
I mean, I think it's hard. You have a patient that comes into the emergency department that's intoxicated, they're belligerent,
Mhm.
they're making a mess, they're using foul language, um, they're potentially harmful to themselves or others. It's honestly, even for myself, you still have to take a step back, honestly,
Yeah,
and resist that urge to have that overcome your total care of a patient.
yeah, agreed. um, and I thought this was an interesting quote from U.S. Surgeon General on that stigma can be more toxic than the addiction itself. And I think this speaks to the fact that, although we recognize again, it is hard for providers to not carry some stigma um, around addiction and opioid disorder. But in the end, when we do that, it makes it so much harder for our patients to not, carry this internal stigma and then avoid appropriate care and avoid, transparent about their needs for, or what's going on in their lives about addiction. And so it creates this kind of vicious cycle. So healthcare providers are certainly a source of stigma. They are most commonly cited source of stigma related to opioid use disorder. And that, really, there's some evidence that no other physical or mental illness is stigmatized more now. Now, certainly, a lot of illness has been stigmatized over the years, but opioid use disorder, in the literature, seems to be one of the most stigmatized conditions. And it often starts when people enter treatment and are labeled within the healthcare system as having opioid disorder. And I guess I don't know if you see this, Dominic. I see this still now where patient may have been in recovery for a decade, but they still have that diagnosis in their electronic health record. And I'll still see comments or, actions, behaviors taken by healthcare providers that reflect that old diagnosis of opiate disorder, even though it's a decade in the past.
Yeah, the notion that once a drug user, drug addict, quote unquote, you're always a drug addict, that comes into play. And I see that a lot in, uh, patients that are getting referred out, to maybe a specialist or in pharmacies. Um, it definitely still happens.
Yeah. There's also some evidence that this is actually worse among seasoned clinicians who've been doing, emergency physicians or others that have been doing this a long time and may have a higher degree of stigma. Some of this, some of the ideas around this are, have these biases that opioid disorder patients are less important among all the patients they're treating. They'd rather pay attention to the patient with acute MI than someone that has opioid use disorder. Um, Also, biases that these patients are poorly motivated, manipulative, violent. And like you said, some of the behavior that the patients show in the emergency department can make it challenging for clinicians, seasoned or unseasoned, um, to not carry these biases. And this leads to lower empathy, lower provider involvement in the patient care for these people, often shorter visits and a tendency to kind of potentially cut corners that clinicians may not do for patients with more, common, less stigmatized medical conditions, and also lead to lower patient engagement and retention for these people. So again, worse among seasoned clinicians. We covered that already. Particularly to emergency medicine, um, there are challenges related to we as emergency providers experiencing the more severe cases of opioid use disorder and the more extremes of the combination of substance use along with mental health. Anything else you'd comment on that, Dominic, in terms of unique findings for emergency clinicians?
I mean, the thing is, most of the time you don't necessarily have a relationship with a patient. So the challenge of that, like I said earlier, the patient is in most likely, the deepest part of their addiction. Um, Whether they're interested in seeking treatment or not, um, sometimes that becomes a barrier. For example, if someone doesn't want treatment, then why are you here? Just get out, that kind of mentality. I think, like Joe said, the combination of mental health and um, substance use makes things even more challenging for emergency physicians. Patients can be very disruptive, very agitated, and potentially dangerous. That makes things challenging as well. It's hard to see through that and get the patient to a place where they might actually be in recovery when they're at one point during their visit in the emergency department are very violent and agitated, to see through that and actually work with the patient and to help them detox and get them to a place where they might actually get into a place of recovery. I would say on the flip side, also some of the stigma with seasoned clinicians, we're seeing a large amount of effort put towards medical students to change some of the
Mhm.
stigma um, that healthcare providers have. I think in the next 10 years, you'll see a new generation of doctors that have much more knowledge of addiction, um, and more motivated to help patients with this disorder.
Yeah, agreed. It's certainly, even when I trained, it was not part of our medical student curriculum to address any of these underlying, issues around stigma for opioid use disorder, as well as other, conditions that we commonly treat in emergency medicine and other aspects of medicine. Um, I think another challenge that, you mentioned how, emergency physicians don't have a long ongoing relationship with patients. So we often don't see the recovery side and the positives of what can happen to these patients. Like you said, we often see them at their lowest point, and so it creates some challenges in having, the amount of empathy and desire to really engage in their care that we would otherwise potentially have. And then time and resources are an issue throughout healthcare, often very pressing in emergency care where, other acute resuscitations and trauma are impacting care of everyone in the department, and so sometimes limit the ability, and kind of make it easier to fall into the stigmatizing behavior of spending less time on the care for these patients. Alluded to some of this, but some of these held beliefs that fuel stigma, external stigma around opiate use disorder, has to do with, you know, prior ideas and beliefs that addiction is primarily a moral problem or a spiritual deficit, um, whether it's a character disorder and, an issue of willpower, and that, many clinicians were trained in a time, and including myself, I think in many ways the community I grew up in and, often held beliefs around opiate use and other substance use as really being an issue of willpower and character rather than a disease. And so I think changing clinicians' viewpoint around the fact that opioid use disorder is very much a disease more akin to diabetes or chronic kidney disease or other diseases helps kind of shift shift one's view to decrease stigma, related to opioid use disorder. Any other thoughts on that, Dominic?
Um, yes, I think it's a good way to look at it is substance use disorder is a chronic disease of it's basically a brain disorder. Look at it as a brain disorder that is impacted by environment, genetics, um, but it definitely the cycle of addiction is within the brain. That's the way I look at it.
Yeah. So I think, and that's often like something I find myself reminding, other clinicians are in our department, whether it's our nurses or trainees, is really harping on the idea that this is a chronic brain disease that requires ongoing care and attention to, both the emergency care, the linkage to recovery, et cetera, that, any other patient that has a brain disorder in our department deserves, et cetera. So really combating that problems around understanding of what addiction really is and combating this idea that, you know, patient's willpower is involved in this. I mean, we all have willpower, but this is a disease that needs ongoing management. I think another
That's
thing that sometimes impacts stigma is the misconceptions about treatment effectiveness, and many physicians, simply aren't aware of the effectiveness of the current medications like buprenorphine for helping patients get into long-term recovery. Any other thoughts on that, Dominic, in terms of about treatment effectiveness and where clinicians lie with that?
um, yeah. I mean, as an emergency physician, you might see a certain patient come in over and over, intoxicated or requesting treatment or help. But it is a brain disorder. The treatment of the brain disorder is normalizing the brain chemistry with medications, uh, therapeutic interventions with counselors, um, and recovery coaches. The whole treatment is targeting the brain disorder,
Yeah,
but physicians don't know about that. It's becoming more and more um, apparent to our knowledge base, but it's still a misconception about how can anyone be treated when they're in such a dire straits.
right. Now, in terms of, internal stigma, um, one of the challenges is, we as healthcare providers often are creating this environment where patients easily can internalize and have stigma that leads to behaviors that end up, making it harder for them to get into long-term treatment. And so some of that may be in terms of hiding addiction, so not being transparent to friends, family, or even healthcare providers about their addiction. And I mean, certainly I've seen patients that that will hide their opiate use from me as their treating physician in the emergency department, um, partly related to just internal stigma and fear of how I will treat them, fear that I will treat them differently than I otherwise would if I didn't know they had opiate disorder use disorder. Um, I think some of that too is like fear that I won't treat their pain if they have a very painful condition that, that I would give any other patient potentially opiates, IV opiates for, say, a fractured, bone or something. Um, so this idea of being labeled as an addict is very real and often leads patients with opioid use disorder to avoid treatments. In the end, though, hiding 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 aspects of the addiction, you know, ultimately leads to worse outcomes if patients are avoiding talking to their clinicians or talking to providers about how they can actually go into recovery and find help. Any other comments on that, Dominic?
I think you know it's so true about the worsening of the addiction by internal these basically being embarrassed.
Hmm.
Um, they hide the stigma, they hide the addiction. Their family is not able to even see it at times because they're hiding it. People that have addiction are very good. They can be very manipulative and very good at hiding um, the issue at hand from their family, from their employers. Um, it's very difficult for people to get into treatment if they have a full time job that doesn't have the potential for them to go see a physician on a regular basis, to get help, to go into treatment, to go into rehab. So trying to keep all those plates spinning is very difficult for patients, and they hide it. They hide it very well, and a lot of times they come when their addiction becomes worse, and they hit rock bottom, and then everything starts from there.
Yeah. Yep. So in terms of reducing stigma, I think some of what we've already talked about is directly relevant to reduction, particularly around education around what opioid use disorder really is, how it's a brain disorder um, that doesn't reflect a patient's necessarily their willpower or their character, et cetera. I think the other thing is having providers extensively having extensive network of providers that are aware of what medications can be used to treat patients. And so one thing that is already making a big impact is changes to the X waiver related to prescribing of buprenorphine, which occurred, just in the past year. But it used to be you would have to physicians would have to go through somewhat lengthy course to have the appropriate DEA clearance to prescribe buprenorphine. Fortunately, that's been eliminated so that any clinician, any physician can prescribe buprenorphine to help these patients. Nonetheless, there's still a lot of work that continues to have to be done on educating physicians on how to use buprenorphine, how to prescribe it, and allaying a lot of fears that continue to exist around the prescribing of buprenorphine that I still am, just about every week am helping um, either a trainee or a seasoned physician understand that no, they don't need to fear prescribing this patient buprenorphine when they're having withdrawal from opioid use disorder.
Yeah, I think there's a lot of work to be done with physicians. This is one of our one of the papers that we use in our emergency medicine departments to show that there's guidance for emergency physicians on how to treat people with buprenorphine. Um, some of the barriers for emergency department physicians, clinicians to treat patients that come into the department is to have them start the medication buprenorphine, which is a very effective medicine to help people with opiate use disorder, and get them into treatment outside of the Department of Emergency Medicine. So that's some of our work that we've done with the Southeast Michigan Foundation to link emergency departments with outpatient providers that can continue the treatment and help people continue their recovery.
Yeah. I think actually, one thing that we've found very useful particularly in our main hospital in Detroit at Henry Ford, is that by bringing in peer recovery coaches in our department, that in itself has done a lot towards kind of normalizing treatment and reducing some of the stigma associated, partly because, these recovery coaches can really talk the same talk with the patients and then also bring this like different level of empathy that our other clinicians, our nurses, and our other physicians trainees all see. So it helps them kind of see how to approach these patients with maybe a higher degree of empathy than they're used to doing. That I've found to be a game changer, at least within our institution.
Yeah, recovery coaches are amazing. They're so
Mhm.
good. They're kind of similar to the sponsors that Alcoholics Anonymous has, but they're continuing to help the patient navigate treatment, continue to help them with their recovery, and they're valuable.
Yeah, very much. We talked about this, combating stigma through, education around addiction being a chronic brain disease. It's not a moral failure. Genetics, certainly genetics, environmental influence, risk for addiction, and that recovery is possible. And, I think also highlighting, stories of where we've had big successes with, our patients having recovery can be powerful as well. Words in, this is certainly, um, I think a lot of this is entering the mainstream of clinical education, but, really like using words in a intentional manner to avoid creating a culture of stigma and really normalizing medications for opioid use disorder. So, emphasizing, part of the term MOUD is emphasis on medications that are safe and effective, emphasizing addiction as a disease. Um, and I think related to medications, pointing out to our colleagues that they really do reduce mortality substantially, often by 50% compared to no treatment in some studies, and that they double treatment retention when we effectively use them. So changing the language around, you know, pointing out that relapsing is not a failure. I think we see that a lot in emergency medicine. We see patients that relapse again and again, but helping, the patient see that it's not a failure and ourselves internalizing that's not a failure and then working toward recovery is part of it. So, I mean, I grew up in I don't know, a culture where we used all this language on the right, which continue to create a culture of stigma, using things like ex-addict, drug offenders, hooked on drugs, but instead changing the language about persons with opiate use disorder, emphasizing disease, persons living in recovery. It's really changing the language to go with this disease model and not go with a lot of the slang around what we've used for opiate use disorder patients in the past.
Funny thing is, a lot of patients will still use
Mhm.
the list on the right there. Um, Sometimes you find a moment where you kind of correct their terms they use, but you got to choose your timing appropriately. But I would say most people that have opiate use or other substance use disorders, they will still use this terminology. So it's going to take a long time for providers and also people with this disorder to use these new terms.
Yeah. Yeah, I think, related to this terminology and the stigma, it's, like I certainly taken care of, a number of patients over the last few months with opiate use disorder that, refused to consider taking buprenorphine or other potential medications to assist them because they insisted that, or they had a fixed belief that they were an addict and that this was, in their own language, they're addict and this was their own willpower issues without really, themselves recognizing that this was a disease where they really could benefit from medications rather than trying to just quote unquote tough it out with willpower. So it's a lot of education for our patients as much as our, providers and other healthcare colleagues. So some other terminology, and certainly, this is just a snapshot of the terminology, not meant to be exhaustive. There's a lot of ways in which we can change the way we talk about addiction, the way we talk to our patients, and help them, understand how to talk about their own disease. So in terms of what else to do, some of this is structural and coming up with like routine ways to educate and have programs to continue to reach out to clinicians can be beneficial. Sharing statistics on the effectiveness of medications, whether that's from the medical literature or in some ways, ideally could come out of one's own institution in terms of, data on what kind of success your group is having or your institution is having. I know through some of the funding that came through MDHHS and Community Foundation in Southeast Michigan, our department was able to create data to actually report back to our group as to how often we're prescribing buprenorphine, how often we're engaging these patients in peer recovery services. So it helps build momentum and provide, actionable feedback on where your department or your institution stands. And again, potentially highlighting success stories. I know, Dominic, you see a lot more of these success stories through your outpatient addiction work. You want to share anything about that?
Yeah, it's there's some things, like taking care of a patient that's pregnant and then seeing her come back into the clinic with healthy baby. Someone that's in treatment for opiate use disorder is very, very motivating, very, very
Hmm.
good. People that get back to work, they reestablish their family relationships. Um, yeah, like Joe said, there is relapse, there are setbacks, and once you know that and you kind of accept that, and as a provider, it doesn't get you overly frustrated. Um, you can see through, the forest and see a pretty good outcome on a lot of patients. Not to say that everyone does great on their first
Hmm.
attempt, but any positive outcomes are good.
Yeah. Yeah. So a few other, potential things to kind of structurally improve your group's, you know, uh, ability to decrease stigma related to opioid use disorder. Um, could consider things like surveying healthcare staff attitudes, to get kind of a pulse on, what people are really thinking in, potentially an anonymous way towards marginalized patients. Um, some groups have done things to track stigma related complaints, so like reporting systems for patients or advocates. We haven't done this formally, related to opioid use disorder stigma, but we do have a tracking system for patients or their advocates to put in complaints. And, frankly, a lot of the complaints we do get are related to stigma, that may be opioid use disorder, maybe in other conditions as well. And so there are ways to, get a pulse as to what your department is really treating patients that may be marginalized. And patient satisfaction surveys, I think a lot of us use those in various ways. May have different opinions on the effectiveness of those for emergency medicine, but they are regularly employed. But a lot of this is to create, you know, data and also create a culture where you're paying attention to what stigma is affecting those that might be marginalized in your department, and having a culture related that is interested in improving on that. So I'll go through a case. This is, anonymized, but certainly someone I've seen a number of times. So this case was a 25-year-old male with opiate use disorder, came in with withdrawal symptoms, admitted to using daily heroin, likely that contained fentanyl, and had a recent overdose event where a friend had to, fortunately, a friend that was also an opioid use disorder was in the same room and had a Narcan kit. So did give nasal administration Narcan. At that time, he didn't seek medical help, but it kind of, he said it shaked him and he wanted to consider, um, you know, trying to go into recovery and find help. And so I offered him buprenorphine and to work with our peer recovery coaches to potentially get into a recovery program, but he declined. Um, so I guess I'll throw it to you, Dominic. What would you do for this gentleman at this point, or how would you talk to him?
So I would, definitely having your peer recovery coach, talk to him would be helpful just to have him on the same level. I would ask him, why he's declining.
Hmm.
What is, not to harass him or anything, but just try to get into his reasoning. Is it some sort of stigma? Um, is he so deep into his addiction he can't see, out of it? Has he had a negative effect, experience with buprenorphine or potentially methadone? Trying to find out what his reasoning is um, for that. I guess if he still declines, then he declines. He's not ready for treatment at this
Hmm.
time. But having him have a contact person to come back and, or feel welcome to come back into the emergency department some other day when he might feel um, interested in recovery, have that opportunity to express it to him.
Yeah. Yeah, no, I think that, yeah, that's great advice. And, it demonstrates being willing to engage and like digging deeper. I think one thing I see, in opioid use disorder and in other areas is, you know, clinicians when they're busy, sometimes will, yeah, at least they'll do this basic step of offering treatment, but then when a patient doesn't agree with them, we'll often just, discharge them or let them go without really engaging and spending the time to kind of dig a little deeper and see if we can get to the bottom of what maybe internal stigma is influencing a patient's decision making or what else may be, limiting their care. So engaging a little deeper can help a lot. Now, another case, taking care of a 45-year-old female. She has an abscess of her left forearm, likely from injecting opiates in it. And your team is performing incision and drainage. We're using some procedural sedation. And one of the nurses we're working with expresses frustration that this is taking time away from other patients to treat this addict. How would you talk to your colleagues about this? I find this to be a challenge, when you're, I think for me, it's sometimes easy to not necessarily always engage in these sidebars with colleagues around, stigmatizing language and behavior. But what's your take? How do you respond to this, Dominic?
I mean, I guess it depends, right? I mean, are you going to take, there's pretty much three avenues. You just ignore it,
Hmm.
which is on some level unethical, I would say, as a
Hmm.
physician. Number two, address it right then or do a sidebar later on. There's all kinds of teaching moments. You have to pick the way you do it most effectively. Um, it might be very busy. There might be some very critical patients, and this is taking time away from those critical patients, which is true. But still, this is a patient, and you have to take care of this issue as well. That's how we work in emergency medicine. We multitask. That's it. You multitask every single minute of your shift. But addressing this in an effective way to colleagues. What I find is a lot of times my colleagues will say, "Hey, I got a family member that needs help. How can you help him or her?" So those are things that kind of come back around because they know that I know how to take care of patients in this realm
Hmm.
too, even outside of our emergency department. So you kind of build trust, but changing stigma takes time.
Yeah, agreed. I think it's right. Having an intention to respond, but it's often like a slow drip over months or years by reminding colleagues that hey, this is a disease that we need to treat like anyone else, and reorienting people to our mission and the disease and slowly changing language and behavior around is important, but does take time and creating relationships with colleagues in that area. So with that, I guess I'll open up any other thoughts on stigma, Dominic, or ideas around what we as healthcare providers for these patients can do. Um,
I mean, I think the slideshow speaks for itself. There's internal, external stigma, doing our best with the knowledge that we have, both in emergency medicine and addiction medicine. I think hoping to bridge those barriers for people getting treatment and helping, you know, providers to learn more about um, addiction as a brain disease is important. Um,
yeah, agreed. I think one last thought on my end is that I don't think I always used to, really appreciate how much fear a lot of our patients with opioid use disorder may have, and that their fear of how we're going to treat them, fear of how, fears related to their jobs, their families, et cetera. And so, trying to, engage with them at that level, and really kind of addressing their fears sometimes can do a lot to establish trust with them and help build you know, the trust to get them on, appropriate medications and get them into rehab. And again, like our peer recovery coaches are usually good at engaging with them at this level. And so it's helped teach me a little bit more about how to really approach them. So with that, I really appreciate your input, Dominic, and
Yeah.
important topic, and one we hope we can continue to make an impact on in Michigan and help a lot of the patients that are suffering from this disorder. So thank you.
Yep. Thanks, Joe.
Great. And here's our contact info if anyone wants to learn more, as well as tools from the Community Foundation of Southeast Michigan about opiate use disorder resources and training material. For anyone interested in more material, please follow those links. Thanks.